Let's pull up Teams. All right, so we are so honored this afternoon to have Dr. Camila Arnaudo speaking with us today. I actually heard Dr. Arnaudo at Labor of Love earlier this year and was amazed by her presentation and the work that she is doing. And I'll allow her to share more about what she does. She can do it probably better than anyone, I think. And just speaking on substance use disorders and maternal mental health, and really just bridging these conversations on how we can support moms, and the program that she has helped establish in Bloomington as well. So anyways, without further ado, thank you everybody for being so flexible today. Dr. Camila Arnaudo. Uh-oh. We're having another. No.
Can you guys hear me?
Yep, you can hear you.
Okay. Right now the display is that I'm seeing myself there. Is that how it's going to be for the whole presentation?
Yes, and I can tell you that the first 2 rows are empty, but the back is full.
Okay. I'm not talking to myself. It's not a practice run of myself here in my office. Well, thanks so much for inviting me. I will share my screen and pull up my slides. Make sure I have the right slide deck. Here we go. All right, are you guys able to see the slide deck?
Yes, we can.
Okay, all right, so just as Jennifer said, I presented at Labor of Love, so some of you that were there will see echoes of that presentation here. It's definitely, actually, do you think Jennifer or Tyler, someone could mute there?
Yes, I can do that.
Thank you so much, otherwise it's coming back at me. Oh, thank you, so much better. Okay, so there's definitely some repeated themes from that presentation, but updated a little bit, and definitely stay till the end because I'm going to be talking about our Indiana CHAMP program, the last few slides, which is our new program that offers consultations to prescribers throughout the state of Indiana. So please stay till the end so you can hear those slides because they're going to be really important. It's our newest program. So here we go. We're going to talk about perinatal substance use disorder. I don't have any relevant disclosures today. Just a little bit about me for those that don't know me. I'm an addiction psychiatrist and I work in Bloomington. I've been here 15 years. I work with perinatal people with both general mental health conditions and also with addictions. I'm the director of the Addictions Treatment Recovery Center, the medical director at least, here at Bloomington. I help Bloomington Hospital, and that's where I'm coming to you guys from today. I'm also on the Indiana Maternal Mortality Review Committee and adjunct faculty at the med school, and most proudly right now, the co-director with Dr. Mike Metrick of the Indiana CHAMP program that you'll hear about at the end of this presentation. Some of our learning objectives, we will jump right into these. So first of all, let's talk a little bit about what are the characteristics of substance use disorder in the perinatal period? How is it different from substance use disorder in other periods? So first of all, what is an addictive disorder, right? What is a substance use disorder? The broad category that it fits in is an addictive disorder. It's basically, we believe that it's a brain disease and that it involves compulsive behaviors. And in terms of when you're talking about drugs, continued use of drugs despite negative consequences. These behaviors lead to persistent changes in the structure and function of the brain. Specifically for substance use disorder, the criteria that we're looking for includes tolerance and withdrawal, but those cannot be the only two things that happened. There has to also be a lot of behavior that people are doing, um, such as, unsuccessful efforts to cut down, spending excessive time obtaining the drugs. They're continuing to use them even when negative effects are happening, and they're not able to fulfill major life roles. There's negative things keep happening, but can't seem to stop doing it. They're just really drawn to whatever the substance is. That was the technical definition for those that were at labor of love. You've seen this slide. It's one of my favorites. Is from a group out in Cincinnati. People who had lived experience put this map together, and it kind of, puts into their words and their images what I was just talking about. So life is chaos. People are experiencing homelessness due to their substance use. They're, losing children to the system. They don't have cars, so they can't quite get where they need to be to get their treatment. All kinds of problems are happening. And don't worry if you didn't catch all the details, because that image is going to come back a few more times. So the perinatal period, a lot of us think of it as a time of opportunity. People are driven to make changes to protect their children that they're not always really capable or able or interested in making just for themselves. They put their children first. Any of those of us who are parents are very aware of this. And because there's so much healthcare that is delivered during the perinatal period, it gives us lots of opportunity to engage with individuals that are, trying to attain recovery. But there's also a lot of challenges, changes that people face during the perinatal period, especially the postpartum period, that we don't always account for. For example, previous traumas can be reactivated. Mental health is often destabilized because of some of the hormonal things that are happening, but also because of the traumas being reactivated. And there's also the perinatal period is actually a time when there's greater risk for domestic violence. Many times partners themselves have been, victims of trauma and abuse, and the pregnancy can reactivate things for them, and there can be other reasons why there's stressors that lead to some of these problems. And also something that we've discovered through our work in the Maternal Mortality Review Committee, that people with diagnoses of substance use disorder do face a higher risk of mortality around the perinatal period compared to people who have substance use disorders but are not pregnant or postpartum. So it is a risky time for people with substance use disorder. A word about language here. Sometimes I am using the word women because a lot of these studies were done before our language became more inclusive. I try to use the term pregnant people to include people who identify as different genders, but when I'm quoting studies that were done specifically with individuals that were identifying as women, I'm using the term women. But that is not to make anyone feel excluded or not having a place in this conversation. So in this study, which was with Foray and her group, they looked at different characteristics of substance use disorder in women. This is not pregnant women, this is just any women. And they discovered that women comprise about 40% of those diagnosed with substance use disorder in the US. That percentage is actually growing, and that 18 to 29-year-old women are the most likely to develop substance use disorder, which is also a time when many people are becoming pregnant. And the rates are rising, as I just said. The other important thing is that women tend to progress from first use to substance use disorder more quickly. They tend to have higher rates of polysubstance use and also higher rates of psychiatric comorbidities. And as I've already mentioned, many women have history of childhood trauma and intimate partner violence who also are diagnosed with substance use disorder. So polysubstance use, which I've already alluded to, is really the rule. The more we go along in this epidemic, then it is like an exception. And when you're taking care of an individual who has polysubstance use, instead of having only problems with one substance, it increases the complexity of what you have to treat. It tends to decrease the rate that people are able to attain recovery from substances. It increases negative effects for fetuses and neonates. we are finding that opioids and also and even more so amphetamines are the greatest rising rates wise in terms of when multiple substances are being used together. THC is also rising quite rapidly, I should say, especially because of the legalization in so many states. Not in Indiana, but most of our surrounding neighbors have legalized it. And then we also have to consider the fact that most of the individuals we're going to be taking care of are also using tobacco or nicotine vaping products. So really, if we include nicotine and tobacco products, we're looking at virtually 100% of people have polysubstance use who are using other substances. Very, very high rates of polysubstance use. Here's a graph that was looking at pregnant people who had opioid use disorder, so their primary substance that was identified as being opioids, and they were looking at rates of polysubstance use in both rural counties and urban counties. And they found that both in rural and urban counties, the rate of polysubstance use in comparing 2007 to 2016, the rate was rising of people using multiple substances. And just as I mentioned earlier, this is looking at people who use opioids as their primary substance. The most rapidly rising second substance that they were using were amphetamines, both in rural and in urban counties, and especially in rural counties, which Bloomington and Fort Wayne were both, considered rural counties. So considered to be in rural counties. And so I think we're experiencing quite a bit of amphetamines here, and I'm assuming that's similar to what you guys are experiencing. The other important thing that complicates perinatal substance use disorders are psychiatric comorbidities. This is from a paper that I wrote with one of my colleagues and friends, Basha and Draka Christou, when I was in fellowship. And we basically found that the rates of co-occurring psychiatric comorbidities in patients who were pregnant with opioid use disorder range between 21 and 72%, with mood disorders and anxiety disorders being the most commonly found, but then PTSD and personality disorders also being quite prevalent. And again, this is something that complicates the treatment because you have to treat this as well. But in our research, we found that it doesn't necessarily mean that patients were less likely to succeed. What we found is when mental health disorders were considered, patients with mental health conditions actually stuck to treatment and gained recovery at rates similar to or better than people who did not have a comorbidity. So it doesn't have to make things more, doesn't have to make the rate of recovery worse. It just has to be addressed. Trauma in persons with perinatal substance use disorder, extremely underappreciated, in my opinion, problem. We know they're extremely high. Research in this area is limited because of underreporting. PTSD we know is more prevalent in the perinatal populations. And again, there are rates out there, but we know that they're underreported for sure because PTSD is actually fairly complex to diagnose. The traumas that people are experiencing can be related to past birth trauma, but they're also related to childhood sexual abuse, sexual assault as an adult. They can have other forms of trauma, previous incarceration, IPV. And as we know, I'm sure this has been discussed in this conference already, early childhood adversity and trauma, leads to this toxic stress response, which is quite negative for the body and increases the risk for developing a substance use disorder and makes the treatment more complicated. This is a slide that I made from data in the 2020 Maternal Mortality Review Committee report, which is available for free on the Department of Health website. So you can download it and read it. So something really interesting and troubling that we found through our work is that 65% of pregnancy-associated fatalities 65% of people who died during or 1 year after pregnancy with pregnancy-associated death causes had DCS involvement. So that's a staggering number if you think about it. And this For some of these individuals, they had DCS involvement as an adult, meaning they were, being investigated or their children had been removed from their care. 3.3% had these reports only when they were children, but not as adults. And then nearly 9% they were both the victims of childhood abuse and then were being investigated as possibly causing trauma to their own children. So this is a really, really like staggering number, and just really gives us a sense of how many of our individuals who are dying from during the pregnancy and postpartum are facing trauma and involvement with the system. Okay, so based on what I've already spoken about in your own experiencing working with perinatal substance use disorder, you're probably already thinking of a bunch of the barriers that might, be occurring here. So I'm going to go back here to our slide of what did the people themselves experiencing this say. If we look down here, some of the things that they described as barriers included things like lack of transportation, feeling failed by the system, feeling really stressed, trying to keep all the ducks in a row to keep CPS away. Let's see, what else did they say? They felt like the nurses down here at the bottom were wild cards. Sometimes the clinicians were barriers because they didn't know much about addiction protocols or what to do. Another big thing up here, we're going to talk about stigma, the scarlet letter of addiction. They feel like people didn't trust them. It was hard to get employment. And yeah, like these are some of the things that got in their way. Which makes us think of Maslow's hierarchy of needs, right? A lot of the things that are going on for people when they're in the midst of addiction is that physiologically they're not safe, right? There's safety in terms of, having resources, a home, that's a problem. They don't feel like they belong, and their self-esteem is terrible. So how can we expect people to self-actualize, right? To really be able to move forward. We got to take care of some of the things here at the bottom of the pyramid. And that, of course, includes those very basic things like childcare, housing, being able to return to the workforce. These are all things that when they're not present, are major barriers. This is from a recent paper by, well, not that recent anymore, I guess, 2018, by Mishka Turplan and some other researchers out in Baltimore. They were trying to understand when were perinatal people, when were they experiencing overdoses? These were not necessarily overdoses that were always fatal. So what they found is something that we're going to keep talking about in this presentation, is that just like we were saying in the beginning, pregnancy really is a moment of opportunity. And substance use overdoses did decrease, as you can see in the middle of the chart, when people were in their second and third trimester. And then as they enter the postpartum period, that started to increase. The top is just all overdoses. At the bottom, they have broken it up on whether people stay on treatment, buprenorphine that is, or whether they don't stay on it. So obviously people who are not receiving treatment are much more likely to have overdoses. This is from Indiana. This is data from the 2020 report that I brought up earlier. And this is to show that when we look at deaths for pregnant and postpartum people that were associated but not related to the pregnancy, the number one cause was overdose that was either accidental or undetermined, so not a suicide. And many of these were in individuals who had substance use disorder. The majority were. Also, suicide, as you can see, is the fourth leading cause, and homicide was the second. And these homicides were very commonly in individuals who had substance use disorders as well, but substance use didn't directly lead to their death. This goes back to the one slide ago when when we were looking at overdose deaths in Baltimore, or overdoses in Baltimore. In Indiana too, we find that the timing of the overdoses and the deaths related to substance use disorder in pregnancy trends towards what's called the late postpartum period, so 43 days to 1 year after they had given birth. And why do we think that's happening, right? Well, we can see here in the blue line, these are pregnant individuals, and the red line, these would be non-pregnant. And we see that with pregnant individuals, just like with the overdoses, the reason there are less overdoses is there's less drug use as people progress from the second and third trimester. And then once they give birth, deliveries right here, the substance use starts to increase. And why does this happen, right? I'm sure if I was there in person, you guys could give me some of why you think it happens. One of the big reasons is that what we call the fourth trimester, right? There's not really 3 trimesters, there's 4. And the fourth trimester is the first 12 weeks postpartum. And anyone who's had a baby here, who's helped out a friend who's had a baby, knows that those first 12 weeks are super challenging with disrupted sleep. There's hormonal changes, adjustment to new parenthood, just a lot of triggers. It's a very risky time for intimate partner violence. Often people have to return to work before they're ready to. There's financial stress. Also, if you yourself were a person who had maybe like not the best parenting experience or some early childhood trauma, now having to care for a baby can be very triggering of some of your own trauma and memories, and your wishes that people had taken better care of you can really get in the way of trying to parent a baby. And again, most of these little guys, these little babies that come out, they're little, they cry a lot, they don't give a lot back. And I think when people are pregnant and they have substance use disorder, they're just so hopeful that the baby is going to be the thing that helps them, change their life, turn their life around. And that's hard for a little bundle of crying, throw up and poop to do right in the beginning. And no matter how much you love them, they're really not giving a lot back in those first 12 weeks. Additionally, this is the perinatal care timeline. This is to remind us that not only do we have a baby that requires way more care from you when they're on the outside of your body rather than on the inside of your body, you are also getting a lot less sort of support during that time, at least from the medical community, right? In most OBs, including the place I'm co-located with an OB clinic one of the days of the week, and when I'm there, they follow the same protocol, right? The first you see your doctor quite a bit while you're pregnant. You have about 10 to 14 visits, but once you deliver, your first visit back is 6 weeks later. So halfway through this very challenging period. And we know that for people who are dealing with substance use disorder, they're highly likely to discontinue postpartum care. In other words, to miss that 6-week appointment, and also to start missing appointments with their substance use disorder treatment team. There's not a lot of literature on this, but they've done some voucher-based like incentive programs, and where they pay people, or give them vouchers or different things to keep them coming. And even in these programs where there's rewards for coming, the engagement drops off in the postpartum period. And so when they've done focus groups to ask postpartum people, like, why did this happen? The things that people said was, number one, that the fourth trimester wasn't really addressed. So their doctors didn't really talk with them or address what was happening in their lives. There was also a lot of discomfort around certain areas, like they didn't want to have to disclose certain things. For example, co-sleeping, which is, we have a very black or white kind of rhetoric around co-sleeping in the medical community. And so patients didn't want to come in because they didn't want to be asked. Or breastfeeding. Maybe they had tried it and they had stopped, and they felt embarrassed to admit these things. Also, brown and black individuals had very specific fears related both to being reported to DCS or other authorities, and also had a feeling that they weren't taken very seriously and their concerns were minimized. So people who are in the postpartum period, they're just not feeling that we're really listening to them. And a different study by Peacock and Chambers, they also did some interviews with postpartum women and who are in recovery, and they asked about what was happening, like why are you guys disengaging with treatment? And they did these interviews, and then they looked at the interviews for different themes. And two of the themes that they found were how I see myself and how I am seen by others. And if you think back to the chart, that we had before with the drawings from the individual, that scarlet letter, right? That's how they see themselves. And how you see yourself in terms of stigma, I like this chart that I adapted from a paper from Corrigan et al. In 2018, where it talks a little bit about like, how does this stigma even happen, right? First of all, people become aware that there is a stigma, like the public thinks that people with substance use disorder are dangerous or problematic. Over time, you start agreeing with this, and you're like, yeah, you know what? People with substance use disorder are dangerous. Well, I'm a person with substance use disorder, so I must be dangerous, right? And it starts to impact people's self-esteem or self-efficacy because they see themselves as part of a group that is maligned. Interestingly, there's been studies done by Bernice Pescasolido here in Bloomington, Indiana. She's part of IU School of Sociology. She's one of the main folks there in the medical sociology department. And many years ago, she studied psychiatrists, in particular psychiatrists who worked on inpatient psychiatric units. And she found high levels of self-stigma associated with how psychiatrists were seen by other members of the medical community. So self-stigma occurs in many areas, not only in substance use disorder, but it's very prevalent and it's a big barrier to treatment. And one of the things that it causes is isolation, and isolation leads to lack of treatment, disengagement with treatment. That leads to an increased risk of overdose, which leads to an increased risk of maternal mortality. And unfortunately, as this diagram points out, the healthcare system actually imposes quite a bit of this stigma on people with substance use disorder. We can do something about it, and that's what we're going to be talking about coming up, by changing how we engage with our patients. So what are some of these strategies, right? Number one is connection. Because really, if we think about addictions and substance use disorder, what it takes to reverse this cascade that I just showed of isolation is connection. That's also what people with substance use disorder who created this diagram that I've been using throughout this presentation, this is also what they said. They said that my doctor stood by me even after my pregnancy. They didn't leave, and also it's a little bit cut out, but I think you can see where it says non-judgmental support makes a difference. So just, being able to put aside any judgments that you have about people who use substances and really trying to see them as individuals and trying to have empathy, putting yourself in their place. I always like to think about all the habits that I have that are not beneficial in my life and how hard it's been for me to change those, and then try to magnify it by about 10 times, since we know that drugs release way more dopamine, into our brain than some of the things that people who don't use drugs struggle with, such as food or like not wanting to keep up a healthy exercise habit. Those things, are way easier to change, and most of us are still not able to change them. So I think it's, just I tend to be really impressed by what my patients are, trying to do on the daily basis. Wow, my email is popping up here. Okay, we don't need to know about my kids going to the dentist. All right. So what are the different levels that we want to intervene? There's government level, medical system level, and individual level. At the government level, we want to focus on policies. At the bottom, if you remember that Maslow's hierarchy, this is like the very bottom level of the pyramid. It's the biggest, and nothing can happen if the bottom isn't taken care of. So things, policies that increase fair and safe housing, access to food, access to childcare, transportation, adequate insurance access and coverage, and then reproductive rights and services so that people have access to contraception and family planning and other things that they need. Also, under government control is the criminal justice sector, so decriminalizing of drug use, expunging felonies for low-level drug offenses, allowing people to be employable, and then looking at child protection services, or in Indiana, it's called Department of Child Services, really focusing on family preservation and making sure that their treatment is trauma informed. I didn't include it here, but also looking at like the individuals that work in criminal justice and who work in DCS, providing them, a good living wage and adequate training and support to do their very difficult jobs. At the medical system level, we need to have greater workforce development, because obviously there's not enough of us. There's not enough silos between different treatments. So between medical and mental health, between mental health and substance use disorder, integration, again, it goes back to connection, right? That first slide with all the hands. When we integrate our care, we increase knowledge, comfort, empathy for patients with substance use disorder, and for the doctors and not just the doctors, because we're in a better shape than a lot of other people, but in terms of how much care people give us. But just everyone who works in this group needs our support. Also, when you have integration of care, you have more detection. You're thinking more about it. You also think that it's your job, right? You may be an obstetrician, you may be a primary care doctor, a pediatrician. It's also part of your job to try to identify individuals who are struggling in these areas. Also, many people just don't want to go to a psychiatrist. As nice and as great as I think I am, many people never get a chance to find that out because they're just too afraid to come meet me. But they're not necessarily afraid of their OB or their primary care doctor who they've known for a long time. And so being able to break down those silos and provide treatment where people are already comfortable is really important. Not to mention that when you're pregnant and you probably already have one or two other children plus your significant other to take care of, having to go to additional appointments in additional locations just makes it way too challenging. And there just aren't enough places to go anyways. So the next part, I'm not really going to talk today about individual level interventions, but I'm happy to answer questions about that if people want me to talk about what can you do as an individual. But I am going to talk about strategies for increasing capacity, because in order to break down these silos and in order to increase the workforce that can treat these disorders before we've actually had more people hired and more people trained to do this. So how do we train everyone who is already a doctor or a nurse or a therapist or a person, any kind of person working in this field? How do we get everyone up to speed and on the same page about substance use disorder and pregnancy? One intervention is called Project ECHO. And this is the QR code for the Project ECHO that we have at Indiana University School of Medicine. So screenshot this, or do this little QR magic and get yourself on this website and register to join us. These are great seminars that you can attend. There's a bunch of different tracks. The way it works is, oops, I apologize. I'm going to go back. I did not mean to do that. Okay. The way this works is that we do a short didactic for about 15, 20 minutes. Then someone presents a case for 10 minutes. And then the community and experts like myself give feedback on complex cases. So you can network, you can learn what to do for your patient. You can present a case. It's super fun. You can learn a lot. There's a ton of tracks. So please register. This is one way to break down the silos. Another way to increase access to care is intensive case management. I think they're probably presenting at this conference too, but I borrowed their slide just to make sure people are hearing about this program, Indiana Pregnancy Promise Program. This is for individuals who are pregnant or postpartum and who have Medicaid and have a history of opioid use disorder. And they provide all kinds of resources, care coordination. They help get prior authorization set up. Just a great group. I referred someone to this program yesterday. I just got on the website and got the information from my patient while she was in the room with me and just set her up so that she's going to be able to get connected with a case manager. So great program. If you have other people with substance use disorder who don't use any opioids, they can still get high-risk OB case management. And this, you want to screenshot this for sure. These are all the case managers for all the various, not branches, that's the military, but the various insurance providers that provide Medicaid in Indiana. These case managers are awesome. They're big attendees of our ECHO, so they are really sharp on addictions. They know what's going on and are very, very helpful to our patients to get, again, connected with the right services. And these are both of these programs are through the phone, so it doesn't require your patient to go to any additional places. Finally, just as I promised, we're going to close out hearing about perinatal access programs, of which Indiana CHAMP is one. Perinatal access programs are statewide programs. Sorry, and there's about 25 across the United States, and the goal is to break down those silos and expand the capacity, right? Make it so frontline providers, OBs, primary care doctors, specialists that are not psychiatrists can treat mental health and addictions in the perinatal population. And perinatal access programs involves three like areas: training and toolkits, resource and referrals, and then the consultations, which is sort of like what they're really famous for. This is a map to show the various programs around the United States, and I put us in there, our Indiana CHAMP. We're green, everything else is red, just to make us stand out a little bit in our logo. We just launched in March, and we are slowly but surely, starting to get the word out. And we want you all who are providers, so you are people who are prescribers, to get this little QR code. The green one on the right is to register. It's free, it's statewide, it's funded by the Department of Mental Health, so DMHA. It is staffed by people like me, so psychiatrists working for the School of Medicine. We're ready. I'm on the shift today. No one's called, so if you have a question, you can be the first one to call for me today. And you can ask me any question about perinatal mental health or addictions or resources, and I'll do my best to answer it. We're open 9 to 5, Monday through Friday, except medical school holidays. And the way it works, just this little slide here, you would call this number, 317-274-2400. There's also a way to put the consult in virtually, like through the computer, if you don't want to call. One of our navigators, Carmen or Dylan, will answer the phone. They will take your information, get a little bit of information about your patient, and then they'll ask you if you want a phone call right away, or if you want to get a phone call tomorrow, later that same day, or a different day, and schedule it for you. And then we will talk to you. We'll call you back within 30 minutes, and you can, we'll have some information already about your case. We'll get some more information. We'll make some recommendations. We type up a little report and then email it to you so you can have it to refer back to. Like I said, this is nationwide. Our own CHAMP is just for Indiana, so you have to be a provider in Indiana to use this. And it's launched now. It's ready for you now. So some conclusions. Substance use disorder and overdose is the #1 cause of pregnancy-associated maternal mortality. The rates continue to rise in the US while they're dropping in other countries. Our state is greatly affected by this problem. The substance use disorder in the perinatal period is very complex, with high rates of polysubstance use and psychiatric comorbidities and trauma, numerous barriers that we've discussed, and especially stigma being one of the greatest. And connection and integration of care is one of the ways that one of the best tools that we have to try to reverse this trend. And I thank you so much for having me. These are all the different teams that I'm on, and I'm so grateful to them, because I obviously couldn't do this alone. I need a lot of connection to and a lot of support in working in a very rewarding but complex part of psychiatry. And then I have all my different references, so you can refer back and read more about any of the things that I talked about. And then I'm going to stop sharing so you can see me. There I am. And I'm happy to. I didn't see there's any. Okay, no, nothing in the chat. But if people have some questions about CHAMP or about anything else that I said, feel free to ask me.
Thank you so much for your presentation. We have about 5 minutes. Are there any questions that somebody might have to speak into the microphone? I think we are good on questions at the moment. I think I've worn them out today already. It's 1:40. We are a lot of information, but we do have access to these slides. So after the event, we'll be giving you access to be able to pull them up to contact Dr. Arnaudo and just to learn more about what she's doing. So thank you so much for your time today. We really appreciate it. And yeah, we'll be in touch.
All right. Thank you for having me.
Thank you.